Hello guys, welcome to the Parson series, and today we will be doing the part 9 of chapter number 8. So if you remember, we were doing with the clinical examination and learning the beautiful concepts of clinics in ophthalmology. Today we are going to start with the tonometry. Tonometry is one of the basic tests that we start doing in the clinics, and this is the very first test that we actually teach the interns, or we show to the students coming for the postings. Easy to learn and reliable technique. Okay, we can rely on it for the screening purpose, and a very basic test that we are going to do if you are a first year resident in ophthalmology. So this is a very basic one. Tonometry is what? It is the assessment of the intraocular pressure of the eye. We all know that there's a pressure inside, and what was the normal value? Normal value is 11 to 21 mm of mercury, and we require a normal range of intraocular pressure in order to see that the eyeball is maintaining its normal shape. Now, it is one of the cornerstones for the diagnosis of glaucoma, and it is also essential in the monitoring of anti-glaucoma medications. Now, I think this is a wonderful thing. All the time when we talk about the tonometry, the only thing that we tend to say is that for glaucoma, but a very important thing is that it is also used for the monitoring of the anti-glaucoma medications. A very thoughtful line, because obviously when you start with the anti-glaucoma drugs, you require a guide on which you have to work. Otherwise you keep on giving the drugs, maybe it's going in the lower range or there is no effect at all. So obviously monitoring is a very important part, and you have to do it with the tonometry. Now first we start with the subjective method. It may be done digitally in the same manner as testing the fluctuations in the other part of the body, and we can do by two fingers placed a short distance from one another above the superior tarsal plate. So I'll be showing you in the video also. We do it with the help of two fingers. So usually what we are doing, we are using the index finger. We ask the patient to look downwards, and we are doing digitally over our superior tarsal plate. And a very important thing is that you have to ask the patient not to close the eye, because if patient is closing the eye, orbicularis oculi will contract, and that will lead to the falsely high intraocular pressure. So you have to ask the patient to look downwards and does not squeeze the eye or close the eye. Instruments known as the tonometers have been devised for measuring this intraocular pressure. So the first very basic kind of tonometer that we use is the indentation tonometer. Indentation Short's tonometer, very important. It actually measures the depth of indentation of the anesthetized cornea. Now, there is a very unique thing about Parsons, that each word do matter. See, in the very first line they have sent so many things. The name of the tonometer is Short's. It's a type of indentation tonometer. It is measuring the depth of indentation of the anesthetized cornea. So you have to give the topical anesthesia. The principle of indentation is used. We have to measure the depth of indentation. The principle is that whatever is the depth of indentation, that will be proportional to the intraocular pressure, and the name of the instrument is Short's. This is produced by the weighted stylet, and it is measured by a lever which travels over a scale. Now, the depth and the volume of the indentation, these actually are dependent on the intraocular pressure and the distensibility of the ocular walls. Now, a very important thing is that when we are using this instrument, we have to measure that how much amount of indentation is going on. So that depth of indentation, the volume of indentation will give you an idea that how much amount of intraocular pressure is inside this eyeball. And the weights that we are using is 5.5, 7.5, 10 and 15. So you could be asked also this thing, that what are the extra weights that we are using. The extra weights that we are using is 5.5, 7.5, 10 and 15. The greatest accuracy which can be attained with the weight by which lever is deflected by 2 to 4 mm. And the greatest accuracy is attained with which weight? The weight which is able to deflect the lever by 2 to 4 mm, that is the best, because you have got so many weights. So how to decide that which one is the best for measuring the intraocular pressure here? So whichever is giving you the deflection by 2 to 4 mm, that will be considered as the best one. Alright. Now see this, first of all concentrate on this picture. They can very well show you this picture and they can ask what is going on. So can you see, with the help of these two index fingers, they are seeing the digital tonometry. So this is nothing but the digital tonometry. I will write here digital tonometry. Okay, here we are going with the digital tonometry. Then if you see here, this is your Schwartz tonometer. This is your Schwartz tonometer. We have got different parts here, and can you see, this is your pointer. This is a pointer here, and this is your foot plate. This is the foot plate here. We have a plunger here, a lever. So what you are doing when you are placing this foot plate over the anesthetized cornea, this pointer is going to move, and we have got the calibrations here. You have to see which reading is being pointed by this pointer, and that reading is actually converted into intraocular pressure in mm of mercury with the help of conversion tables. So see, this is the proper technique. They are showing that how to measure the intraocular pressure. Patient should be supine, and you have to anesthetize the cornea. You have to give the proper information about the test. You have to take an informed consent from this patient. Then you ask the patient to look at its own thumb. Okay, you have to bring the cornea in the central fixation. That is very, very important. And then you have to take the footplate of this tonometer, and you have to actually place it over the surface. So when you are doing all this, then what will happen, this pointer will move and the pointer will point towards the reading, and that reading will be taken and it has been converted by the nomogram conversion table. So here is the table here. Okay, here is the table. So you have to select what weight you are using. Suppose you are using the basic weight 5.5 and you get a reading here. Okay, you get a reading of 6 here. So what will be your intraocular pressure then? Then this will be 15. Actually it is a 14.6 to be very, very accurate. So in this way we can use it. All right. Now the instrument is calibrated so that the equivalent reading in mm's of mercury can be read from a chart. Alright. Now Schwartz tonometer is often inaccurate. Why it is inaccurate? Largely because of the wide individual variations in the rigidity of the corneoscleral coat. Now another important thing is that though it is good for the screening purposes and we are largely using this tonometer for the screening purpose, the main problem is that this tonometer is actually dependent upon indentation, and indentation depends upon the rigidity of cornea. So we cannot exactly rely on its values, because if it is more rigid, then we will have falsely high values, and if it is less rigid, I will get falsely low values. Alright, however, the tonometer is actually useful for obtaining the approximate reading, particularly for the comparative measurements. To allow for this inaccuracy, the type of tonometer should always be cited and the reading expresses minus 20.6 mm. Okay, that is Schwartz tonometer and this grams. So what happens, because the amount of fluctuations could be there, so it's always very, very important that whenever you are actually quoting the intraocular pressure, you have to tell that what is the reading did you get, what is the weight that you are using, so that the other party also come to know that some degree of variation could be there, and he or she can also doubly check it. The readings are not accurate in steep, thick. So they are not accurate when we have steep, thick or irregular corneas, high myopia, hyperopia. Hyperopia means hypermetropia. With the use of miotics, vasodilators, vasoconstrictors, and intraocular surgery, especially the vitreoretinal surgery. So this thing is again very useful for your academic purposes. They can ask you a questions that what are the places where this reading is actually not accurate. So wherever we have steep corneas, thick corneas, irregular corneas, we have got high degrees of refractive errors, maybe myopia, maybe hypermetropia, or we have used certain drugs like miotics, vasodilators, vasoconstrictors, or we have some surgery on the eye like the vitreoretinal surgery. All these places it's not very good. Now, the another kind of instrument that we have at our disposal is the Applianation Tonometer. So this Applianation Tonometer is more accurate in comparison to the Indentation Tonometer, and it is based on a different principle called as the Imbert-Fick principle. Instead of measuring the amount of indentation, this is assessing the amount of force needed to flatten or applanate a known area of the cornea. Now what is happening actually, if I tell you the Imbert-Fick law, if I talk about the Imbert-Fick law, Imbert-Fick law says that pressure is equal to the force upon the area, right? Pressure is equal to force upon area. So what is the amount of force which is required to applanate? Applanate means flatten. What is the amount of force which is required to applanate or flatten what? The cornea, and what area? Okay, so you divided by what area of the cornea you have taken. So this will be already known. This will be already known. We are actually flattening a known amount or known area of the cornea, and therefore we can say that it is the fixed area tonometer. Therefore we can say that it is actually a fixed area tonometer, or I can say it is a variable force tonometer. And because you know the pressure is actually calculated from the force upon area, and the area is already fixed, so I can say actually that this pressure is directly proportional to the force applied. So whatever is the force required to flatten the amount of cornea, initially we have got convex cornea and then we have to flatten it. So cornea becomes flattened. So whatever is the force which is required to flatten the cornea, that will be giving you the pressure. So pressure will be equal to the force into a constant. Okay, we will be multiplying it by the constant so that we get the pressure in the mm of the mercury. So this is simple physics. All right, now if you look back here, see, they have clearly said that what is the force required to applanate a known area of the cornea. So what type of tonometer it is? It is applanation tonometer with the fixed areas. Now in this process, the factor of the ocular rigidity is offset by an induced capillary force acting in the opposite direction. Now here also we would have been you know, affected by the rigidity, but actually we are cancelling it down by a capillary force which is acting in the opposite direction. So we have taken into consideration that there will be a force here that will be affecting the rigidity. So we deliberately induce a capillary force in the opposite direction, therefore no correction is required for the ocular rigidity here. Now when the cornea is flattened by the application of a plane surface on it, intraocular pressure is directly proportional to the pressure applied and inversely proportional to the area that is flattened. So I told you that this will be directly proportional to the force. And how much of aqueous is displaced? Aqueous is only 0.05 ml of aqueous is displaced, and the basal intraocular pressure is negligibly altered. Now the most popular applanation tonometer is actually Goldman's applanation tonometer with the Hack straight slit lamp. In it, circular plexiglass plate 7 mm in area is applied to the anesthetized cornea. So again we are using the topical anesthesia. You have to be very sure that when you are using these tonometers, you have to use the topical anesthesia. And what is the amount of cornea? We know that a fixed amount of cornea has been applanated, that is 3.06 mm diameter of the cornea. Okay, the constancy of the area of applanation is ensured by the indigenous duplicating the optical device. Now this particular area of flattening is chosen as with this, the force of 0.1 gram exerted by a spring and lever system corresponds to an intraocular pressure of 1 mm of mercury. So this particular area, if I take into consideration 3.06 mm, okay, so you have to see that a force of 0.1 gram, this is exerted by a spring and lever system, and this is corresponding to the intraocular pressure of 1 mm. Now the patient is seated at a slit lamp after anesthetizing the cornea, and you also require one more thing here, and that is your 1% fluorescein dye. Because what happens when you are applanating the cornea, whatever Myers you are getting, you are not able to see because cornea is transparent. So I require the help of a dye. What dye I am using is the 1% fluorescein dye in the palpebral sac. Now on placing the plexiglass plate on the cornea, so circular meniscus of the fluorescein is actually seen as two half circles or Myers. So what happens? if you look at the Goldman's Applianation Tonometer, the probe is actually something like this. Probe is something like this, and this is touching the cornea. Okay, so when this is touching the cornea, you get a circular area, circular mire. But what happens, this probe contains the biprism or the double prism. It contains the biprism or the double prism. So this will get splitted, and I am going to get two semicircles. I am going to get two semicircles, and basically you have to align these two semicircles in such a way that their inner ends are just touching each other. So this will become your final reading. This becomes your final reading. Alright, so this becomes your final reading. So whatever reading you are getting when the two mires are just touching each other, that becomes your final reading. You have to take this reading and you have to multiply it by the constant. Okay. The most accurate reading is obtained when the, as I told you, when the two inner edges of the mires coincide. The mires should not be too thick or too thin because of the excess or scarcity of fluorescein, as the intraocular pressure will then be over or underestimated respectively. Now another important thing, if I am going to get thicker mires, will I overestimate the intraocular pressure or I underestimate the intraocular pressure? So see, they have said that when there is excess, okay, when there is excess, I will be overestimating it, and when there is scarcity, there will be underestimated respectively. So I think now you don't have any doubt about the overestimation and the underestimation. In the presence of excessive corneal astigmatism, two readings should be taken at right angles. The average you can take. The Applianation Tonometer, a very important thing, it cannot be used in the scarred corneas. So this actually gives you a clue that there will be a different and a separate kind of tonometer that we will be using in cases of the scarred corneas, because this tonometer is not going to work in cases of the scarred corneas. Okay, so can you see, this is your reading where you are going to take the final reading of intraocular pressure. So this is the system of the mires, which is actually normal, okay, where you should be taking the reading. Okay, now there are two things that could be there, like they are here they are not aligned. They are not aligned because they are passing each other. So the mires should not be passing each other. This is also not right, and when they are at a distance from each other, then this alignment is also not correct. So you have to be very precise that what is the correct alignment. Means they should not be crossing each other and they should not be at a distance from each other, right? Then see here, if you see the lines too thick and lines too thin. So if the lines are too thick, they are falsely low IOP will be recorded, a very important thing. And if the lines are too thin, falsely high IOP will be recorded. Again, a very important thing, because nowadays the type of questions they are asking, they are not going to ask you directly the Goldman's Applianation Tonometer. They are going to say that all of the following are true about, and sometimes they don't even say that all of the line things are true about what. Okay, so you have to gather the lines that actually they are talking about the Applianation Tonometry. All of the following are true except. So the thicker lines will give you falsely low IOP and the thinner lines will give you the falsely high IOP. Alright. Now a handheld version. So we also have a portable version of this Goldman's Applianation Tonometer. I usually write the GAT for it, Goldman's Applianation Tonometer. So we have got a portable version for this. So a portable version, P for portable, and we have got P for Perkins. So a portable version of the Goldman's Applianation Tonometer is the Perkins Tonometer. Another technique of measuring the intraocular pressure, which is also using the applanation principle, is the Mackay Mark tonometer. So for the applanation principle, we have got Goldman's Applanation Tonometer also, we have got Perkins Tonometer also, and we have got Mackay Mark tonometer also. Movement of a plunger which extends 10 microns beyond a plain foot plate is monitored by the transducer. It is recorded on a paper. The average of several readings is taken and they are giving. So basically it is actually electronically monitored. In the Mackay Mark tonometer, we are taking the electronic reading. Electronic readings we are taken, and there is a facility that you can take a continuous trace of it, and you are using a transducer, you are taking the readings on a paper, so a continuous monitoring is actually possible with the help of Mark tonometer. Then we also have a digital handheld version of the same. So a digital handheld version of the Mark tonometer is actually the Tonopen, while the handheld version of the Goldman's Applianation Tonometer is the Perkins Tonometer. Okay, so this Tonopen is giving you mean and standard deviation of 4 to 10 acceptable readings. Then we also have your non-contact tonometers. They are also utilizing the principle of applanation. So can you see, I can say all of the following uses the applanation principle except. So are you ready for these kind of questions now? So we are non-contact tonometers are also following your principle of applanation. What you are doing here, a warm puff of air is actually projected on the cornea, and a photoelectric cell measures reflected light obtained by a fixed area of the cornea. So two things are there. This is also applanation tonometer, and here also we have a fixed area of the cornea. So this is also a fixed area tonometer. It's a non-contact tonometer, and applanation is done with the help of a puff of air, a jet of air. So this is also called as the tonometry. Therefore, this is also called as the tonometry. Again, an important thing. The time taken for the applanation tonometry is proportional to the intraocular pressure. The average intraocular pressure is approximately 15 to 17 mm of mercury when you are measuring it with the applanation. So I think this is a very important and good concept that we are actually able to do in cases of the tonometry. Thank you and happy ophthalmology.